Hello, everybody. We are live, and it is Thursday night over here with Dr. Kimberly Santiago. I'm so excited about this. Thank you, Dr. Kimberly, for being with us.
My pleasure.
Awesome. Let me turn that off. So let's start. And we've been here chatting. So I just want to tell you guys that if you join us through Zoom, there's always like a pre-show that goes behind the scenes before this. You guys miss if you're live on Facebook or Clubhouse. So for the future meetings, if you'd like to join through Zoom, you get to listen to everything, because I know that we already heard from Dr. Kimberly some amazing information that is not live anymore. But here we go. Dr. Kimberly Santiago graduated third in her class from the University of Washington School of Dentistry, class of 2005, with about every honor and award one could earn. In 2015, she started AirSync Integrative Dentistry, a practice which she owns and maintains together with her husband, Dr. Jed Santiago, in Washington, right?
Yes.
Dr. Santiago has built a comprehensive airway-centric practice that cares for infants, littles, middles, and adults. I love how you fit that. AirSync's approach is, I lost myself right there. Airway-centered care is based on 6 pillars of care: structure, function, behavior, chemistry, posture, and nerve function. Coming soon. Through extensive education, it's here now. We're going to hear about it tonight then. Through extensive education, collaborations, and mentorships, AirSync has, oh my gosh, amassed a substantial offering of orthopedic remodeling techniques, from ALF to MSE to SFOT and everything in between. Infant laser frenectomies, functional frenuloplasties, in-house lactation, infant feeding, or facial myofunctional therapy, and close relationships with community naturopaths, professional bodyworkers, midwives, and more. Dr. Santiago and AirSync are in the constant pursuit of excellence as their practice continues to evolve each and every day so that they can do more and offer the best to their patients. Her never-ending airway journey has been an insatiable quest, but also a beautiful beginning to many wonderful friendships with other providers, airway providers in the world. How do you manage all of that?
It's actually, my tank went empty this morning for like an hour, and then I got
Superwoman.
I don't know. It's taken a toll on me, but we're working through it. We're decompressing for the month of December.
Oh my Lord, you're incredible. You need a trip to Brazil.
Well, I won one, thank God. Thank goodness.
So today's topic is diagnosis and treatment planning of airway patients. We are going to open the floor and give the mic over to Dr. Santiago. If you guys have any questions, you can post on the Facebook Messenger, message me or Tamara on Clubhouse, or over here on Zoom. Just put it on the chat and we will try to get to them. But other than that, the floor is yours. Thank you.
Okay, so I have we're probably not going to make it very far because I never get through anything, but we're going to start with just kind of reviewing a little bit about the pillars that Renata discussed. I'm a product of the Airway Mini Residency by Barry, Raphael, and Mark Cruz. I've done it twice. I'm very close with actually the 4 doctors that now kind of run the show, if you will. It's now called the Airway Collaborative. But I've become close with almost every well-known guru.
Oh, of all the you were one of them now, so.
Oh,
yes.
I almost cried a little bit when you were reading that whole thing about.
Incredible. You're incredible. So honored to have you here. So.
Thank you. So the mini residency is, or at least the Airway Collaborative is now what they're called. It's founded on 3 principles: structure, function, behavior. But through my journey with Roger Price, who I know is listening, and through Ted Belfour, a little bit with Lois Laney, but more with Derek Nordstrom and Angie Tenholder this year. I've now added 3 more pillars to my and Stasha Gomanak, excuse me, I forgot to mention Stasha. I know. And then there's more that just keep showing up in my life. But that's where I now have added posture, chemistry, and as Lois Laney calls it, electricity. But nobody knows what the heck that means. So cranial nerve function, and autonomic regulation, and more. So, so before I'll dive into what an adult evaluation kind of looks like, or at least what my findings look like and how I present that to patients. But I do a very similar exam for adults as well as children. And then infants is a whole nother animal, which I'm not going to open up that can of worms on this platform, because hours to discuss that. But let me see. So my belief, and I talked about this, I think, when we did the clubhouse while I was in the elevator and running around after my children, was every patient that walks through my door or comes to an oral myofunctional therapist or even an ENT, or however they present to a sleep physician, that they get a comprehensive assessment of those 6 pillars. And I know it's my dream one day that that's going to be the standard of care, of course. But so when they come in through my doors, we of course have an extensive interview and discussion about what brought them to us. Often it's James Nestor's book for many adults that walk in, or they're the parents of the children or babies that I've treated over the last few years. So, but then we do comprehensive data assessment, of course, so craniofacial assessment. I know they all have oral myofunctional disorders on some level, because we know they have craniofacial underdevelopment issues or breathing issues or sleep issues. So I leave that to the oral myofunctional therapist to fully dissect and plan out that those diagnoses and treatment plans. But full tongue range of motion, a sleep assessment, which I think is critical. I don't do sleep studies anymore. Well, that might change actually after a course I was at last weekend in Oregon. I'm just, can't. Yep. And I have class this weekend, one more class, but my husband's going with me, so at least it's a date weekend. I know.
Yeah. How old are your kids? Do you guys have kids?
We do. We have 11, 8, and 6. And they hate me. They just think they love me.
My daughter tells me, Mommy, I want life to go back to what it was before. Because after Airway Circle, I don't see you anymore. You had to start this Airway Circle, she says.
But I know she'll understand one day, but we do cherish every moment with them, because
that's what I tell her. I said, listen, you have to enjoy the time that we do have together. We just have to, use it to the fullest, so we don't feel like we're missing whenever we're not together. But it is difficult. And my Lord, with 3 kids, I'm going crazy over here with 2. I can only imagine.
Oh, well, now they're a little older, so they can, play with each other or do independent play, but we play every evening. It's their time, so they know how to make martinis, so they make me a martini, not by themselves.
I can't wait.
I know. Anyway, I'm sorry. We have a ridiculous house. You know what? I was hoping my husband would just think she needs one. I know, but I'm like, I have my water.
Just wait.
Yes, I know. So sleep, back to seriousness, everybody. So with sleep, the Airway Collaborative Airway Mini Residency truly believes in the HRPO, high resolution pulse oximetry, and it's a great screening tool. I'm a dentist, and I do own a sleep test unit, but we kind of shied away from it because I really want to focus on this is to see where this is our baseline physiologically. This is our autonomic tone. This is what's happening with your oxygenation. And then the patient and I can help them decide if they want to have a sleep test. I don't want the sleep study to determine what they do with their health. But if they need medical help, that's when we'll talk about that. But let me see where else we have posture. It's a team approach. It's a collaboration. And so I like to think of myself as the quarterback. I've laid out all the parts that I know that need to get addressed. I can only address so much in my office with structure, both the tongue, as far as the restriction, any other ties, the jaw size, the floor of the nose, how wide that is. And then super cool, we got the light walker from Photona to be able to do the baby lays. And holy moly, guys and girls and everybody in between. I was at this course last weekend. It was Airway and Invisalign, and Photona was part of the sponsor. And I'm like, I don't know what I'm going to learn here. And I walked away not only knowing, and I knew what nightlays would do, but they were showing tongue reduction. So you can shrink the tongue with the laser. It's basically doing lipolysis to the tongue and literally takes those big fatty tongues, even if those airways, even if the jaws are like 40 millimeters wide, but the tongue still just doesn't fit. It was insane. And then I know this is getting recorded, but totally off-label use, because we are treating the soft palate with nightlays. If those tonsils just happen to be in the way, they can get shrunk down to nothing. And they're still there and they're still functional. So anyways, why did I even bring that up? Aside from, so I'm the structural woman. I'm sorry, everybody. This is my life. I'm the
That's how we
woman.
talk. We're good. You're in a safe place right here, because I'm the same.
Oh, good gosh. So I'm the structural person, if you will, and we have Myo in the office, and now with baby lays, or for bigger humans, it's called oral myolays, or smile lays is another term. That helps with the neurological, like the cranial nerve balancing and sequencing and reflex integration. And then I work with, and Roger, you'd be proud of me, my best friend has become, or Paige, sorry, my best friend has become Paige Raffo, who I met many moons ago. She's amazing. She's now doing almost all breath work, Roger, just so you know. She went through Rosalba's program. So I have my people, and it's wonderful. So okay, so let's just go into a PowerPoint, and I blacked out everybody's eyes, so it should be, do I have the ability to share my screen? I do. Okay, let me go back. Do we have any questions, I guess, before I go?
Anybody? Roger was trying to say hi, I think. Let's see. Let me check Facebook. Hello, Dr. Kimberly. Welcome to Airway Circle. Harini.
Oh,
Harini Shidar. Oh, here. Let me turn your volume up, because you're low. Hold on, Roger. Go ahead.
Kimberly.
Go ahead. Oh,
can you hear me?
Yeah, we can hear you.
Yeah, but Kimberly, can you hear me, dear?
I can. It's good to hear you.
Wonderful. How are you?
Oh, crazier than ever. But I'm fantastic at the same time.
You were beyond crazy before we got together.
That is true, but it's been enhanced.
Wonderful. It's been a long time. In any case, wonderful to see you and wonderful to hear from you. And I hope to be getting back to the US as this nonsense is lifted. And then we'll kind of make some things happen again. Let me not interrupt you any further. Off you go.
Oh my goodness.
Bye.
No. Okay. He's such a sweetheart. All right. Well, let's share. I'm going to show you. I'll walk you through what I do. Basically, how I present, or not how, but just what I present to a patient. So this is an adult version. And then we'll go into a pediatric, and I want to kind of just show you what I'm looking for. And there's so many more things that I probably am not seeing, but and that's where we all collaborate together so we can all push this forward. But every day I change my presentation. Sorry, my son is barging in. See, it doesn't happen.
Hey, how are you, honey? Do you want to be famous? Say hi to everybody.
There's a lot of people watching this.
You're so handsome. What a sweet.
And he got rave reviews from his parent-teacher conference today.
Oh.
So, and actually, he's the reason why I got into this. He mutilated me nursing. But thank God he had those cheeks and that face and those overworked buccinators that I didn't know why he had those.
That's why, because I mean, if your tongue is not doing what you're doing, that's a sign that everybody should look at. If that baby has those chubby cheeks that we just love, it's because their buccinators are working so hard to help them swallow instead of the tongue doing the job.
I know. But actually a little squirrel side note. So I didn't start treating infants at that point. My beloved IBCLC, Renee BB, if anyone knows Renee in this area, when she came over and I was having my issues, I had her for my first child for nursing help. Just I think everybody should have a lactation person, regardless of problems or not. But so she was there for the second one, and she's like, "Oh, I think he has this posterior tongue tie." I'm like, "What the hell are you talking?" Sorry, everybody, just curse.
Yeah,
But I'm like, I can't. Yeah, I didn't ask her any more about it. And that was 9 years ago. And so my journey actually didn't start because I ignored her. And then realized it 6.5 years ago that she actually did, of course, know what she was talking about. But super interestingly, when I measured, so I never treated Alessandra because I didn't have the tools yet. But I, of course, the child of the airway doctor, they don't get a proper exam. They just get put in appliances.
Yep.
They get their jaws thrown. They get told to close their lips, tongue up to the palate, breathe through your nose. No proper myofunctional therapy. But I did do I did his range of motion to see what his function was. There was no tie. I swear it was tight fascia, which baby lays would have treated him. So it was a submucosal grade 4. And I swear to God, everybody, I don't know that we should be treating those. I think we have to release the fascia. So that's a whole nother talk we can do another time.
I know.
That's for babies.
Insane.
That's for babies.
And after we're done, I'm going to show you guys a case that I'm doing. Remind me.
Yes. Well, anyway, so it's all his fault, but I love him. He's my sweetheart. Okay. And I'm so surprised he's doing so well in school. We were worried about him, but he's doing amazing. I don't mean to say that, I do love my children. It's all good. Okay, let me get to presentation mode. A little too much on. Oh no. Okay, I don't know.
Give better presentations. What are you trying to say? PowerPoint.
I know. Well, it did an upgrade, so it's got a black box.
Oh, that's what it is. Yes.
Why does it have to get prettier or fancier? Okay. Oh, let's get rid of this. No. Sorry. Okay. I'm so sorry. Okay, we'll just keep going. Okay. So I always review even with a child, I can already start to see joint issues, but I review exactly how their jaws have developed thus far, or how the orthodontist helped them, or how things have regressed. Tongue, nasal space, we all know, everybody that's on here is listening, we all know that the tongue is the architect, in addition to Dr. Kimberly. But I have to trademark my airway, face, and jaw architect tagline, as well as tongue tie surgeon. But these are what we review here. I always put the patient's chief concerns, and my goals are obviously always the same, but eliminate or reduce, everything we see. We want to breathe and sleep optimally is truly the goal. And then I've just started doing this, and I don't know why I didn't do it before, but now I pull all of the comorbidities off of their health histories that are associated with dysfunctional breathing and sleep. And then all of the positive answers off of their, I use the Lamborghini sleep questionnaire for adults. So we review that, and patients, even though we've talked about it ad nauseum at their intake appointment, they look at me like, those are all related. And I don't know, maybe I talk too much, but, and then this crazy slide is to just kind of take them back to why this has happened to them. So it's a good synopsis, and it's really good for, is this all good information? I don't know. Am I doing okay?
Yes, you're amazing.
Okay. So a lot of times when I'm reviewing data with parents or an adult patient, the spouse is not there, even though we are Zooming now for all of it. So this is just a recap of how they got here. And then I'm like, because I feel like I have to scare the poop out of these people to move forward in some cases, especially with kids. I feel like I'm pleading for the child's life, and I shouldn't have to do that. I am their advocate. I am their champion. But I shouldn't have to be scaring the parents. I mean, the data itself does it, but
Exactly.
I was trying to pull as much as I could from what is his name? Matthew Walker. Is that right? Why We
Yeah.
Sleep.
Yes.
Everything in
Beth.
that book scares me.
Beth Sohail just did a live with us all about sleep, and she loves him and she loves his book. But she was so good. If you guys have not watched it yet, please go back and watch Beth's live
Yes.
with us. Fantastic.
Yeah, he can scare anyone after like 10 pages of reading it. Like it's like, thank you, I'm gonna go to bed now. Or I'm gonna go drink my at least 4 hours before bedtime. So anyway.
Wow.
So then I do a dive into front pictures, postural things. There's so many subtleties to posture, and I know a lot of myofunctional therapists who are on here, or if there's PTs, I'm not sure who's on the group, but we do look at posture. And, oh, good Lord. Now there's a 6-year-old in the room.
You're fine.
Okay.
Hey,
You want to say hi to her?
Hey, honey. How are you? Oh my gosh, your kids are so beautiful. Hey, cutie pie. Oh my gosh, you're so cute. She looks like Zoe a little bit. My little one.
She has an intramolar width on her E's of 40 millimeters.
Oh, I am so jealous. I'm a 31. You're amazing.
But we have to correct her vertical next. So, but we had to take a break because we were not.
You know how it is. Yes. Last night I tried to put this spot on Zoe's mouth, and she screamed the whole time, talking about how dare I torture her. She said, "How can you torture your precious daughter?" That's what she told me.
I know. I'm glad they use those words too. Yes, they do. Yes. Yeah. So let me see, where were we going? So a lot can be seen, or what, I'm sorry, I know where it was going. So we're all now kind of tuning into posture, with shoulders and head position. And there's just so many things. And this woman's quite young, but when we see her neck, I should have showed this other recent new patient we did. But anyways, it doesn't look like a whole lot, but just very subtle changes. And then this is a neat, I always look for asymmetries in the structure and as well as the function. Hers is actually pretty similar, but this is from Ted Belfour. He does these chimeras, and sometimes it's really, I'm just going to move along because if she's ever going to see this, I want her to, I don't know that she'd ever watch this, but just looking at, if you look, she's like, I think she's 30 or 31, but look at that reverse curvature there, and there's just so much. So, but head forward, reverse curvature here. I think she's also got loss of curvature of the upper spine, but looking at the Bolton norm comparison, do that with the jaws as well. A PVA line, which I don't know if anyone knows that, but this is how we know how deficient anterior posterior is relative to the base of the cranium.
Oh, would you talk to us a little bit about that? I don't think anybody don't know that.
Yeah, so it's an orthodontic. It's a I use the 3D image, but it's a cephalometric measurement. This is Frankfurt horizontal, which runs from the top of basically the external auditory meatus to the orbitale. So that's the green line. And then we make a perpendicular line and then drag the line to a point. And then that line needs to be parallel. So this little point tells us, relative to the base of the cranium, how well did that patient's maxilla grow forward. And so where the number 97 comes from is a study, and I think it only really applies to Caucasians, which is, it's very irritating. That there's many different backgrounds that walk into our lives, and but the study was looking at all sorts of different risk factors for sleep apnea, but one of the things that came out of it was the patients that were less likely to develop sleep apnea had a PVA of 97 or more.
Wow.
But if you look at Asians, they have short cranial bases, so in the high 80s they may be just fine. So even the Bolton norms are a little poopy because they're based off of Caucasians that were living in Cleveland back in the day. So,
Okay.
but that's a PVA line. So it does give us a goal also. So if we do have a Caucasian patient, and let's say they're 89 millimeters, and we want to try to get to 97, that tells us we need 8 millimeters of growth. And these numbers aren't absolute numbers, because if we can get an airway and a nose, if we have a nose that works with good airflow, passive airflow, and an airway that doesn't collapse, then the number is irrelevant. But it helps tell. Go ahead. I'm sorry.
Sorry, Anne is asking if there are PVA norms for children as well, and this can be done. I'm sorry.
Oh,
yes.
It's an adult measurement.
Okay. I know children.
So when they're like 10-ish, because the maxilla, as we know, is like 90+% grown by then. I do it to show parent. It's not like an official age appropriate to show a parent, but it does
give you an idea if it's way less or close to.
Yeah. So little humans, they don't do that, but bigger middles, older middles.
I love that.
Yes. So let's see. So then we go through the Ceph, where we can see so much. So she did lose curvature of her spine right here. So you could see how, and you can't really see that from the outside necessarily, but I do think that's where that lower cervical hump comes from, is where the upper cervical comes forward. But from long-term forward head posture, you lose that curvature. So the chicken or the egg, the airway was compromised, the head came forward, then the vertebrae compromised. And I think we really have this huge opportunity as airway providers to really work with chiropractors and PTs that are looking at this and come together and realize there's more airway people running around, running amok with neck problems. So, but key things I look for in adults, it's not common I see enlarged adenoids, but I'm looking at how long their soft palate is. I can really show a patient on this view, as well as the coronal, that the roof of the mouth, the hard palate, is the floor of the nose, which we have up here, where their hyoid bone sits. You can see how it's like the front of an arrow. The point of the arrow should be on that turquoise line. And it should be, actually the whole thing should be on the turquoise line, but the point, it should be pointing towards the chin. So a low hyoid is a risk factor, or it's a biomarker risk factor for collapsibility. So that's important to know too. And if we make more room for the tongue and we have great myofunctional therapy, the tongue is going to be able to come up and forward, and that's where the hyoid bone then is more complicated, of course, than that. But and then we can look at this crazy airway. That is a small airway. It looked small, and then so we have AP tiny and we have transverse tiny. But what Lois Laney and what Derek Nordstrom will tell you is it doesn't matter about the size; it's the function and the nerve. How is the electricity and how functional is? I'm a believer in both size as well as function, because physics doesn't discern totally. But let's see, and then I show them airway measurements, lateral, just like I said, transverse dimension, AP dimension. This is one of my favorites, is looking at the nose with the patient and the size of, I can't even see because I have our pictures in the middle, but this person's not, for today's standards, that's not too bad. Although I know we don't want that small, but that's still bigger than I see on a lot of patients. So, but this is also an opportunity, and if I'm boring, I'm so sorry, but this is an opportunity to see at the lower first molar, how vertical are the molars? Because it tells me, do I have room to upright them, or do we have to do SFOT? And there is a procedure where you can actually cut the internal surface of the chin and like widen the mandible that way, but it seems like a crazy procedure to me. So SFOT is a great way to make up for that the ability, well, it gives us the ability to widen the lower. So you can see here, she has a vertical tooth, that lower left first molar, and this one is tilting in, but it determines how much room we have to work with the upper, because we can only take the upper out so much. So this lets us look at septum. I can show patients why they can't breathe through their nose when they don't have a lot of space for air to flow. The neck, look at that crazy neck.
Wow.
So she has a side bend. And her atlas is perfect, right? It's horizontal, but and we have them stand in natural posture. We just have them shake it out and then walk into the machine and say if the posture follows. So she's got not a lot of good stuff happening with her neck. And then I look at it from the top down, and you can see, I mean, the airway is really, of course, it's constricted and narrow right where the vertebrae are off there. And here we go. And then look at the tongue. It's crazy. That's a perfect tongue for tongue sculpt. This is a tongue sculpting tongue. And yeah, I'm excited when we get to do that for her. Okay. She's tied. I think actually she came to us because we treated her 12-month-old. And then, and it's usually interesting when the parents had no idea they were tied or there was restriction and they couldn't elevate the middle and posterior thirds. And then they're like, oh. So anyways, let's see. So these are HRPOs, and I don't know, I can explain it a little bit, but the left column is the RDI column. And then the arousals, the autonomic tone is showing up down here. So this, interestingly, she doesn't have this clinically, if we did a sleep study, she probably would be in the mild sleep apnea range. And from what I see across patients, this number strangely looks low for autonomic arousals. And an autonomic arousal, I'm not going to give a whole huge talk on what we look for in sleep, but you have apneas, hypopneas, reras, and then autonomic arousals. And autonomic arousals are what push people towards upper airway resist. That's one of the defining factors for upper airway, or hallmarks. It's not a defining factor, a hallmark. So based off of this woman's fatigue, I didn't know what I would see in the RDI, but I thought I'd see a huge number of autonomic arousals based on she described how she feels and her severity. So, but it's not just the numbers, it's how does the patient feel? And, we have our numbers, but we got to have that patient feeling amazing. So then I explain everything because again, the spouse is not watching with mom. So, and I've now, the class I was at, because actually I presented this a couple weeks ago, the class I was at last weekend, they use the word sleep suffocation. So how many times do you suffocate in your sleep per hour? So now I put that on but it's true. It's sadly true. So,
yep.
I explain what upper air resistance is. We do a summary of all the findings. Go back into I don't call them the pillars, but for the components. I cannot move this. Hold on a sec. There we go. So structure, function, behavior, posture, chemistry, and nerves. And then we go into what options I have for the patient. So I guess this is a good time to talk a little bit about appliances, but I used to think I'm only going to do gentle things. I started off with Vivos, with DNA appliances, and I'm not going to get started on that. And I know Roger has his opinions also, so we're not going to talk about that. And I'm sorry if I'm offending anybody we'll just put that away. So I'm like gentle, 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 and Barry Raphael is whisper to the bone. So I'm always like, I'm going to whisper to the bone, but the whispering, I don't whisper well. So or the patient doesn't hear the whispers. I don't know. The bone's not listening. So, but I do like the Homeo block. I do like the Homeo block. It's a bit different. So, so my evolution with appliance therapy started with DNAs. It then moved into AGAs. So not the Breathe Institute, the Facial Beauty Institute, Dr. Galella.
Yes.
he actually does not call it the AGA. It's an osteorestorative device. And
Oh,
AGA was what LVI termed it. So he's very particular about, but it's a great term, AGA, because that explains it well to the patient. So,
yes.
so we evolved into AGAs, but AGAs are forward growth, and you get little transfers. So I use it in certain instances with patients, but I was clearly realizing not one tool fits every patient, and you can't have one thing in your toolbox, which is what I thought I had. And then I was like, nope, you can't. And not everybody wants to do fixed or surgical, so you have to be able to fit that patient and vice versa into the right therapy. So so my evolution then went into ALF, and I don't do a whole lot of ALF with adults. I don't, well, I feel like it has limitations for growth. It does many other wonderful things for patients, but I think it's a little limited for me, at least. And then we went into SFOT education back in late 18. But it doesn't change the nasal floor. So that was, and I can explain more of that later. Oh, I did that, I think, on a chat. Maybe it was on Airway Circle. Somebody else did too. But to truly make change, it's not just about changing the oral volume and the space for the tongue. It's about changing the nasal resistance is key. So nasal breathing is king or queen, it's paramount. But if we have a nose that doesn't work because it's too narrow, and we have allergies we have to look at, there's so many factors, so many layers. But my goal is to open up or enlarge that nasal floor it has to happen. And whether that's this way or with AGA, Steve, osteorestorative device, we need to remodel the nasal complex or nasomaxillary complex. It has to get remodeled or enlarged on some levels. So, and then came the MSEs. So MSEs infiltrated life early last year. In early lockdown is when MSEs took over my life. So now when I present, it's often a combination of therapies. Everybody, it's not just one fits. It's not just one tool for
of course, every patient is different, and every patient is going to need a different growth and a different approach.
Yep. So sometimes and often I should say, not just sometimes, unless patients are absolutely adamant, I only want a homeoblock, or I don't want to try the MSE, but let's try the homeoblock first. We have those patients too. So, but it's often a combination of therapies because they don't all achieve the same thing, and we need to rely on multiple modalities. So MSE is now a big common tool in my toolbox. And interestingly, so a lot of body workers think we're fixing this thing to the palate, we're stretching it, we're causing what havoc we're wreaking on the body and the neck. And, for me, I want to get the nose working. And I know the nose is important. I mean, of course I know the nose is important. I know the neck is important, and the cranial rhythm and how everything, I know it's important, but we don't know these answers. And I know a lot of MSE users are not looking at cranial.
Well, you can keep fixing you can keep going to a chiropractor, you can keep going to a physical therapist. Nothing is going to maintain if you can't breathe. You have to be able to get your breathing good, correctly, how you're supposed to be done. Otherwise, everything pulls right back.
Oh yes. So interestingly, I was on a Zoom with my COIS. If everybody knows what the COIS Center is, I'm a graduate from, I cannot believe, 11 years ago. I
just heard about them, and last talk we had, I asked our speakers if they knew about COIS, so I would love to hear about COIS. I had a patient that had it.
Yeah, he's my I don't do regular dentistry anymore, but he was instrumental in my early education as a young dentist. So, but where was I going? Oh, I was on. So we have a little COIS airway group with some really amazing providers, and one of them is a big ALF provider, and she also does craniosacral. So she has this amazing, keen sense of just looking at a face and seeing what's rotated out of alignment. And I can't see it very well. I don't have those eyes. I don't have those hands. But we were looking at some MSE cases, and we actually saw that the sphenoid rotated into position with the MSE. How crazy is that?
Wow.
No. So we only had time to go through 2 patients, and it rotated into position, or at least from both the coronal view and from the coronal and the axial view, it rotated into a better position without body work. So I have no time to go back through my data, but I will totally love to have somebody do that for me. But I think that's so cool. It's pretty darn neat. So
how old was the patient, Beth is asking?
Oh, good Lord. The 40s.
Wow.
I think they were adults. They were adults, and I think they were having myo. They were having other techniques, but no hands-on, no body work. So
amazing, phenomenal.
I just think there's so much sitting in my patient database. I'm like, I welcome Sarush to come and send one of his minions to go through all my data.
You wouldn't have time to take care of your patients if you were doing research. Yeah,
I know. But my data is open for anyone who wants it. I'm happy to share. So I always show patients. So sometimes patients, for sure, I think will need SFOT because of that lower arch, or if they have really thin bone, that's a something. Or they need cortical. Everything is tailored to the age, the sex of the patient. Do we need to go forward? We can actually hook up a reverse pull face mask to an MSE. And in adults, if they will wear it, 14 hours, I don't have that time in my life, but if they'll wear a reverse pull for 14 hours, we may be able to slide the maxilla forward 2 millimeters, maybe 3.
Wow.
And in kids, I have the youngest person we have in an MSE is 7 years of age. Wow. You can correct the class 3. You can move the maxilla forward a centimeter with I don't know how old, maybe 18, but it's crazy. It just translates. It doesn't go vertical because you've opened up all the sutures around the maxilla. It literally slides forward. It doesn't increase vertical. So it's pretty cool.
Wow.
So, but SFOT, it does, you can go anterior. So you can get some AP improvement so that the mandible can come forward. So it's just, again, tweaking and seeing what the patient is up for here. And then sometimes actually we go in the reverse. Sometimes I can't fit an MSE in, so we have to do a little bit of SFOT. It's all just a la carte. I mean, not a la carte. It's all not a la carte. It's just different for every patient.
Yes, I understand.
I think I'm hungry. So, anyways, pictures. And then I interestingly treatment plan homeoblocks as a possible step 3. I don't know what it says, step 2 or 3. But if we still have cranial asymmetries or some occipital atlantal issues or whatnot, we can then put the patient in a homeoblock after we're done with everything to make some minor changes and even upright or change some of the TMJ dysfunction as well. So it's pretty cool.
I was going to ask you a picture of the homeoblock.
Oh, yeah. It's not the best picture. I stole it from Ted's website, I think. But that's a homeoblock. It's one side. There's a unilateral bite block. That's what is the defining feature, and the same on the pod. And the pod is really cool. It was designed for daytime wear. Well, I don't know. I have to ask Ted his real reason. I can't remember exactly, but it's actually kind of like a deprogrammer, a neuromuscular deprogrammer for you. Well, but what I've seen, we've been using it to help get patients out of pain with their joints, and it has worked pretty darn amazingly. In a matter of like 2 months, 3 months, we can get the mandible to come forward and get the patients out of pain before we go, if they're coming in symptomatic, before we go into treatment. So that's, sometimes we just do a pod early on. But if you wear it, if you do a homeoblock, you do the homeoblock at night or for 10 hours. And then you wear your pod for an hour to 2 during the day. And what it does is not head's purpose behind it, but it acts like a myofunctional trainer. So this is something myofunctional therapists might be interested in finding a dentist that can take these for them. But I don't know if you know that, but
I did not.
It forces your tongue to the palate. So every time you swallow, it tones the front of the airway. So it's pretty cool.
Amazing.
Okay.
Anne asked if you could elaborate on the cortical puncture in combination with MSE.
Yes. So if you're a male over 20, if you're a female over 30, it's become standard of care to do cortical punctures. So basically, at the moment, I'm using a burr in an electric handpiece at a really low RPM. Oh yeah, we cut the palate.
It sounds awful. I'm gonna get it done.
No, it's you use a really fine, I mean not super fine, but a fine burr.
Yes. And
you're puncturing until you feel no resistance. So you're going through the cortex.
Thank you, Anne. So, I needed the visual.
Yes.
I'm kidding.
But it's not so, I mean, I actually had that myself. And I was sedated because I'm a horrible patient. So, but I was okay on the other side. But we do this to people all the time.
But it does help a lot.
It does. And interestingly, so as far as treatment planning, how to build the MSE, the goal is to put it, at least this is what is discussed by almost all the gurus, it's to place it between the first bicuspid, like the middle to distal first bicuspid to the first molar area. But the resistance is actually more anterior where the bone is denser. So I have a mentor, and if I get invited back to talk in April or May, I'm going to be learning from him, but he's placing it a little more anteriorly. Or adding more pads. So you'll see, I went the wrong way. So you'll see that a standard one comes with 4 tads. So he adds 2 more little, he solders or welds 2 more little sleeves to the back and the front. And that, he's had success in opening males up to 60.
Wow.
With that and cortical punctures, as opposed to having to do something like dome or big cuts to the maxilla. And if Stephanie is still on here, I was talking about that with her about how it's nice that, and I'm not going to share everything with Stephanie, but we were talking about it a couple weeks ago about how males may not have to go through such extensive cuts to be able to help open up the palate.
So that's what a dome is? The dome is more of a cut?
Yep. So dome is distraction osteogenesis. Distraction osteogenesis. Oh my God, I'm having a moment.
Dome.
Anyways, I can't remember it at the minute, but it's basically you're doing Lafort cuts. So this is done by an oral maxillofacial surgeon. The whole facial is tissue is elevated. And then the Fort 1 cuts are made here. And then the pterygomaxillary plates, you're cut back there.
Wow.
And so it frees up the resistance, because as we're turning it, the resistance is coming from the zygoma area here. So it takes away that limitation for the expander to work.
Makes
but
sense.
that's a
I
lot
had no idea that the dome was that extensive compared to the cortical punctures.
Yeah, and even there's more aggressive forms.
It's better than MMA.
I was going to say,
yeah.
yes, I would try not to, but I would try not to do MMA if I could help it.
Right.
But interestingly, as one of my mentors, Dr. Rick Robley, and Dr. Mark Cruz, both of them talk about MSE and or SFOT should be stops along the way, regardless for MMA surgery, because you don't get the same change in nasal airflow with a 3-piece orthognathic surgery case. You should really do the I can't even talk now. I'm all.
That's why they're relapse
with no. Yes, and no myo.
And no myo, exactly. There's so many people don't realize this. How many MMA cases relapse? And I didn't know about
that tongue. Yeah, that tongue is never taught to get back up in that place. But yeah, so really MSE, anyone who's any of you that are working with orthodontists that plan a lot of MMAs, you really want to suggest or talk to them about transverse development, especially of the nasal capsule, which is what you do with an MSE prior to getting into an that area for MMA. But interestingly, one more interesting thing, and we could talk about kids, or we're already out of time, but I will just talk as much as I know. I told you we were going to get very far. Oh goodness. So I was at the great Richard Ting's office a couple weeks ago, and he is an orthodontist in Orange County. He's placed the most MSEs in this country. And he was saying that most of his patients that were slated for or planning to do orthognathic, they were in MSEs, of course, and they abandoned the MMA because the breathing changed that much with the MSE. Wow. So that's an exciting finding.
Fantastic. I got a question from Chris. What are your thoughts with anyone with osteoporosis, now osteopenia, a year and a half off Prolia?
Oh, and what we can do? Like surgical, like MSE or SFOT post, like reclassed or post bisphosphonates. Is that the question?
I think so. Chris, if you'd like to elaborate, we will listen. And then Anne had also asked, about your norms. What norms do you reference for intermolar width?
What are your numbers? So adults, so depending on the shape of the and the width of the incisors, so for females, I'm going for I'd like to get to 40. Males 40 to 42, but if they're Asian, and Asians have very large teeth, typically very wide, beautiful big teeth, we're probably going to go definitely 42. And the one thing that a lot of people don't realize, and I've only really, unfortunately, it's been a byproduct of doing SFOT or MSE SFOT, is that when you go that big, then you're getting to the sizes of jaws where there is space that's going to remain between teeth because you're so big, and you can mesialize teeth. It just takes a long time. But when you're getting to those jaws that we've seen, those historic jaws where there's so much room for 32 teeth and excess space, there's space because that's so bigger we go, there is going to be excess spaces.
What do you do then?
So you can do, so I have colleagues, and I don't restore, so I, thank goodness, don't have to deal. No, I'm just kidding. We plan.
You sent your best friends to restore those seats, so fill up those spaces.
Well, it's better to plan it at the beginning and tell the patient.
Yes.
We may have some excess spaces. We can close them. It's going to take this much longer, or you can basically do no prep veneers on bicup. And you can do them with, So that's kind of what we have to do. So we have to balance out, is a little space okay? Is breathing more important? Is that what do we want to do? So I know I'm on a tangent as usual, but so I'd like to get, 38 is the low end of
Perfect.
optimal, but 38 is better than 30 or 31.
Perfect. And Chris answered us. She said, yes, best choice. How do you speak? I'm in my car, LOL. She said, basically, would any of these modalities be safe for somebody?
So it depends on who you're working with or talking with. So Rick Robley, again, one of my mentors, he and his surgeon would not, they kind of stay away from patients that were on bisphosphonates. And I don't know that there's a test that we can do to see if it's safe or not. But my periodontist who does my SFOT, we had a patient actually that we just did this with. She was on reclassed, I feel like, and she'd been off of it for a year. And then he did a few different tests where he did like a little bit of a bone removal, let it heal, and watched it fill in. And so he actually did full mouth SFOT on her, and she's okay. She's fine.
Wow.
We're still in process. So that I think what we've learned is it's much harder to move the teeth in the bone. So it's a case by case basis. How long have they been on it? What have they been on? And I don't know that there's a lot of research, but maybe upping their vitamin D and their magnesium,
Yes,
maybe we
that's
can
my thought.
alter their bone quality. But
Very nice.
There was somebody else that asked me about that, and maybe it's Anne that's on here.
Yes, she has amazing questions.
Yes, she asked me. We messaged, and I never answered you about the reflux, and I'm so sorry, but I promise I'll message you back about the reflux.
She's good. She does have one last question. What can you use in a 14-year-old to get forward growth of the maxilla during phase 2? Is headgear your best bet?
So you can do an AGA.
Mm-hmm.
You can do that or osteorestorative device.
Okay.
So you can use an AGA, or I think an MSE with a reverse pull. Those are our two options. So you always have to think if they're AP deficient. Well, I guess not everybody, but if they're AP deficient, they very well may be transverse deficient. So if you're going to go MSE anyways, I would pull them forward at 14. You should certainly be able to pull it forward with the reverse pull.
Wow. So interesting.
But I always like to do transverse first. Is my transverse first, then AP.
Very good. I have one more. Can I go one more question?
Of course.
Nobody's come from Dana Moon. Can you explain SARP? Is it SARPy? I have an orthodontist wanting to do MSE, but he can't find a surgeon to help. He said they all want to do SARP. Is that SARPy? Is that how you say that?
Surgically assisted or rapid palatal expansion. So where are you located, or where is that orthodontist?
Dana, where are you? I can't remember where Dana is. But what is the difference of that and MSE?
So MSE is the appliance. Mm-hmm. So it's a MARPy. All these words, MARPy.
I know.
So MSE is actually the brand name. It's like the Kleenex of the tissues.
Okay.
MSE is literally the brand name. So the picture I showed was an MSE. Right here. This is a brand name. So these are take it off the shelf basically, and you solder it to bands. So MARPy is the family of appliances. It's a maxillary assisted rapid palatal expander.
Surgical. Okay.
SARPy is one of the techniques like DOME. And I'm pretty sure DOME would be considered a form of SARPy, which is where you're making big cuts that are
surgical.
Big surgical cuts. So it's a surgical assist. And that was really, not developed for, but it's because of the older men. Sorry, men.
She's in Rochester, New York.
Oh, Rochester. I don't know, but I'm trying to get, so
Well,
Okay.
Mariana
So
Evans is in Philadelphia. That's not that far.
and Ilya, so the orthodontist that I was talking about that I'm learning from in March, he's been guiding me. He's amazing. His name is Ilya Lipkin. He's in Jersey, and I don't know where in New Jersey, so that's not too far from Rochester. But he's the one who's had success. I don't think he's ever done surgical, like had to have a surgeon do surgical cuts because of how he's learned to position it. So that might be something, Dana,
You know what?
your orthodontist to reach out.
I actually think that a patient of mine is seeing him. He looked all over actually, he almost went to Europe, but he looked everywhere for somebody to do. Well, he needs MMA. He's doing the MSE now, but I think that's what he chose to work with. And is saying, so SARP is more invasive than the SFOT?
Two different animals.
Yeah.
You have to do the SARP. Yes, but it is more invasive.
Okay.
It is, but two different things.
Okay. Oh my goodness. We can just sit here all day. Let's just bring our kids and because they're always with us anyways. This is
it'll be fun.
Dr. Kimberly Santiago. You're fantastic. I don't know. I don't even know what to say. You're so knowledgeable.
Oh,
I love it. Love everything that you share with us tonight.
Oh, you're welcome. If we do this again, I think we all should have a martini in hand and see how it goes.
Then nobody's gonna be able to hold us back over here. We're gonna go on 2 hours at least with a martini.
I know. This is my life story. That's why my appointments go so long at the office.
I know, guys. We cannot ask anymore. We've already gone over time. I know there's some more questions coming in. Thank y'all so much. We are going to have Dr. Santiago back, and it's gonna be called the Martini Hour. MSE and Martini.
Yes. And we'll teach you and how to teach your children how to make them. The secret is keeping your vodka in the freezer, actually. That's one of the secrets. It's ice cold.
I love that. Yes. You know, I keep saying this, whoever built these refrigerators with the freezer on the bottom, the drawer on the bottom didn't have toddlers. Who came up with that? Because my 2-year-old is constantly opening that thing and getting popsicles out and ice cream. I'm like, stop. He's 1.5. He'll open up, grab chicken nuggets out, climb over the counter, put them inside the air fryer, and turn them on. He can cook.
It's amazing. It's amazing.
So he can probably start practicing his martini technique now.
I get. You'll have to get a plastic martini glass just in case of it.
Right. Anyways, guys, this has been a wonderful night. Seriously, we could stay here 3 more hours just talking. So much amazing information. Thank you. We will set a different time for you to come back in sometime next year. I know our agendas are.
My honor. My pleasure too.
Yay, guys. If you guys have not signed up yet, last call right now. I keep calling him doctor, but Roger Price has his class with us tomorrow. He goes from 6 to 10 p.m. Eastern Standard Time. If you cannot watch it live, it's recorded. You have the opportunity to listen to it later. You get 4 CEUs if you're a dental professional. And then next week, we have Dr. Chris Tran. He's an ENT in Texas. Christopher Tran. Very excited about this. And then we're going to break for Thanksgiving. And we have an incredible month of December. I cannot wait for you guys to see what we have in store, especially the last week that we're going to have lives. It's going to be like the 13, 14, 15, 16, whatever those days are right there. It's going to be Tuesday, Wednesday, and Thursday. So save the date for that Wednesday because we don't usually have lives on Wednesday, but it is somebody very important. It's going to be a big surprise for everybody. Nobody knows really who we're having that day, but it's going to be a bombshell. You guys have to write that day down. I'm not saying a word. Nobody can know who it is.
Not even like what discipline you're in?
I can't share anything because I'm going to give it away. I know somebody else asked me today. I'm like, I'm sorry, I love you, but I can't. So write those days down, and then we're gonna break for Christmas and New Year's for whoever celebrates those. And then we come back in January, and we have Dr. Dan Hansen, who's gonna teach a course for us. Oh my goodness, we just have so much amazingness going on. But very excited that you guys are all over here supporting Airway Circle. Otherwise, we couldn't be doing what we're doing. So thanks, everyone. Have a wonderful night. And Dr. Santiago, we'll speak soon.
Thank you, Renata. Have a good night.
You too. Bye bye.
Obrigada. Obrigada.
Obrigada. You don't need me.
That's my one word. I only know that one.
And martini. Everybody knows what martini is. Very good.
Yes. Yes. Okay. Have a good night.
Bye, guys.